Welcome to Conference Highlights, recorded in front of a live audience at an evidence-based perioperative medicine, that's EBPOM conference. EBPOM are world leaders in perioperative education, so why not join us at our next meeting with a special discount for Top Med Talk subscribers. Look us up on www.ebpom, that's EBPOM.com. Top Med Talk.
Today we're going to be giving you a talk from Miles Berger, and it is Postoperative Changes in Cognition, the role of biomarkers.
Good morning. Thank you all for having me here. It's a pleasure to be across the pond to tell you about some of the work our whole team has been doing, looking at the changes in postoperative biomarkers and postoperative cognition. This represents the work of a large team of people, many anesthesiologists who've helped do the lumbar punctures I'll talk about, many of my surgical colleagues, including Dr. Julie Thacker, who's here, and a large number of patients as well, at least for a study like this. So a brief outline of what I'll talk to you about. I'll give a little bit of brief background. Dr. Fleischer has already covered kind of the ASA Brain Health Initiative and some on this, so I'll be brief about this part. I'll talk to you a little bit about a study we've been doing called MADCO-PC. I'll tell you what that awful acronym actually stands for and what we've been doing in that study, both in terms of CSF biomarkers, cognitive testing, and functional brain imaging. And then I'll end with a few sort of practical thoughts on what we can all do to prevent these postoperative neurocognitive disorders, especially for our older patients. So just some brief background. This is the key slide from a paper that was published a couple of years ago by Sharon Inouye and her colleagues looking at the long-term cognitive trajectories after postoperative delirium. And the patients who had delirium afterwards are in blue. Those who didn't are in red. Both groups take a small hit cognitively about a month or two after surgery. Both groups recover by an intermediate period of 2 to 6 months. But longer term, the patients who had postoperative delirium early after surgery had worse cognitive decline 3 years later. Interestingly enough, this trajectory, when I first saw Sharon present these data, I thought immediately of this paper from Mark Newman and colleagues at Duke, far before I ever got to Duke, back in 2001. In which they just did cognitive testing before and after cardiac surgery and showed that the group of patients who had a 1 standard deviation drop on cognitive testing right after surgery at hospital discharge, again had this initial drop by definition, but they recovered by an intermediate period of a few months to 6 months. But then again, at 5 years, they did worse than the patients who didn't have that early drop. Now, both of the two slides I've showed you can be interpreted actually in two different ways. And this is where I think a lot of the controversy in this field lies. One interpretation is that anesthesia and surgery did something to these people that, interfered with their cognition or damaged their brain. They display worse neurocognitive function early after surgery, but they recover by a few months later. But yet over a longer period of time, that deficit shows up again. That's one interpretation. And I think that's compatible with the data. An alternative and completely plausible explanation, completely consistent with the data, is maybe there was some other latent trait that was different about these two groups of patients. Maybe the people that show cognitive dysfunction early after surgery, whether by cognitive testing or by delirium screening, maybe those patients had something a little bit wrong with their brain to begin with, maybe something that we can't measure on cognitive testing, but perhaps they had some Alzheimer's disease pathology building up in a subclinical fashion or something like that. These patients then show a little impairment after surgery that sort of unmasks the surgery or the anesthesia unmasks that latent trait. They get better by an intermediate period of time, but then they do worse in the longer term, again, because of this latent trait. Which of these views is correct, or the extent to which one versus the other is correct, or the extent to which one versus the other is correct in different groups of patients, I think is one of the biggest questions for our field. And a lot of this sort of gets at this idea of what actually causes these disorders, or what are these disorders at a neurobiological level. This is from a review article our group published in Anesthesiology earlier this year, where we pointed out there's many different mechanisms that could potentially play a role in these disorders and probably do play a role to varying extents among different patients. I'll briefly go over these. There's Alzheimer's disease pathology, which I'll discuss more in the next slide. There's changes in cerebral oximetry and cerebral oxygen delivery. There's anesthetic dosage, which I'll come back to in a few slides. There's all these other physiologic changes, mean arterial pressure, changes in serum glucose and glucose delivery to the brain, carbon dioxide, temperature, hemoglobin, etc., particularly in cardiac surgery. Then there's all of the inflammatory response to surgery as well as the counter-regulatory resolving response that helps resolve these inflammatory pathways afterwards. There's all the vascular mechanisms that are involved both in cardiac surgery in terms of embolic load as well as in orthopedic surgery and other types of surgery that induce emboli. And then finally, there's dysfunction of the blood-brain barrier. We know that even outside of perioperative medicine, older adults have a less active or less functional blood-brain barrier, which allows one to theorize that perhaps some of the peripheral inflammatory response might travel up into the brain through that leaky barrier. The study I'm going to talk about in the next part of this talk focuses really on Alzheimer's disease pathology. And to summarize probably over 20 years of work by many groups around the world in one cartoon, basically every mechanism that's been implicated in Alzheimer's disease pathology has also been shown to be accelerated by anesthesia, surgery, or both in both animal models and or in vitro systems. So just to review, Alzheimer's is characterized by two specific types of pathology. These extracellular amyloid plaques here that are produced by the production of these amyloid beta monomers, which then aggregate into these plaques. All parts of that process can be accelerated by anesthetic drugs and surgical stress. Anesthetics have been shown to increase calcium-dependent neuronal excitotoxicity. They can also modulate inflammation, and we know surgery itself induces a large inflammatory response. And finally, in Alzheimer's disease, the second type of characteristic pathology is these intracellular tangles of this hyperphosphorylated protein tau that's normally associated with microtubules. And both tau production and tau phosphorylation can both be accelerated by anesthesia and surgery. However, the question of, well, does anesthesia and surgery accelerate Alzheimer's disease? Or if you have anesthesia and surgery, are you more likely to get Alzheimer's? It's a very, very contentious and difficult question to answer because we now know from the work of our colleagues in neurology and neuroscience that Alzheimer's disease doesn't suddenly just appear the way one comes down with a cold one day. It actually the pathology starts decades before the cognitive symptoms ever start, which is a somewhat frightening idea. Many of us are probably already displaying some of this pathology, but have no cognitive signs, no clinical symptoms of memory dysfunction or anything else, and won't for 20 years, or perhaps won't even during our lives, because we'll pass on from other causes. But nonetheless, this model of Alzheimer's disease, where the pathology starts much earlier than the cognitive symptoms, suggested to us that we might be able to study whether anesthesia and surgery might increase the risk for Alzheimer's disease by asking a more proximal question: do they increase these biomarkers or these pathological processes, amyloid beta or tau pathology? And if so, do perioperative changes in those pathways correlate with who gets cognitive dysfunction after surgery? And that led us to the somewhat poorly named study, MADCO-PC. Still a young investigator, still working on the nomenclature here, which stands for Markers of Alzheimer's Disease and Neurocognitive Outcomes After Perioperative Care. And the primary outcome in this trial was the correlation between the perioperative change from before to either 24 hours or 6 weeks after surgery and CSF tau levels, and whether that correlates in a continuous fashion with cognitive change from before to after surgery. So just to briefly review the inclusion-exclusion criteria, we were looking for patients over age 60 who were having a major non-neurologic, non-cardiac surgery that was going to last at least 2 hours. The reason for non-neurologic is we didn't want the effects of neurosurgery that might bias or conflate with the results of the cognitive testing we were doing by direct actions on the brain. We stayed away from cardiac surgery, even though there's a large literature on cognitive change after cardiac surgery, because we wanted to do lumbar punctures before and after surgery, and we didn't want to be doing that in the setting of high-dose heparin administration and anticoagulation for bypass. We enrolled only English-speaking patients. We excluded pregnancy, prisoners, chronic anticoagulant usage because of the LPs, and claustrophobia, because as I'll talk about, we also wanted to do functional MRI scans. And this is a brief diagram of what the trial actually included for each patient. There's sort of a lot going on. We had patients undergo cognitive testing before surgery within a month prior. About half of those patients also underwent functional MRI scans, looking at resting state functional activity and functional connectivity. The day of the surgery and preoperative holding, we obtained a blood sample and a CSF sample. So just to clarify, we're doing lumbar punctures purely for research here. These are not patients getting spinal anesthetics. We use a spinal anesthetic kit to do the LP, but it wouldn't have otherwise been indicated for the surgery. And there's no benefit to the patient directly of having the LP. We don't do a spinal. We don't give any medications via the spinal needle. Then they get treated with either propofol or isoflurane gas for the anesthesia. Postoperatively, we screen for delirium using the CAM-ICU instrument for the first week afterwards. We obtain a blood and CSF sample one day after surgery to look at acute postoperative changes in CSF or serum biomarkers. And then at 6 weeks later, we repeat the full cognitive test battery. The idea here is that this is early enough to detect cognitive effects of surgery and anesthesia, but far enough out that at least the initial acute effects of hospitalization have usually dissipated. In other words, the patient's not being awakened at ungodly hours for blood draws. They're usually no longer on opioids, etc. At that time point, we also obtain a functional MRI scan again, at least in the set of patients who got one previously. We get blood and CSF again. And then at 1 year, we do cognitive testing and again get blood and CSF. In this talk, I'll just review the 6-week data in these surgical patients. So here's the flow of patients through the study. We screened about 1,600 patients. We consented and enrolled about 140. Of those, 110 came back for 6-week cognitive testing, and a little bit less than half of those had fMRI scans that I'll be showing you the fMRI data from. All told, including the 1-year data, this means we did 392 total lumbar punctures for research for this study. So what did the data look like? Well, here's CSF tau levels. So what you see is this is the group median, and this is the median absolute deviation. So this is approximately 100 or 104 patients here within these error bars, roughly. Any patient who had a value that was greater than 1.5 times the standard deviation or median absolute deviation at any time point, we graphed as a single dotted line. So these each represent single patients that were outliers at any time point. So what you can see is while the line is completely flat essentially in all patients, there are some of these outlying patients who have much higher values to begin with, some of whom perhaps change a little bit afterwards. But we weren't powered to look at subgroup effects like this. If you look at phospho-tau, you see a very similar pattern. The group as a whole is entirely flat, but you do have about 10 or so outlying patients who start sometimes lower, sometimes higher than the group median, but go up to much, much higher levels that would be quite clinically significant, at least in the CSF Alzheimer's disease field. These levels of upwards of 80 would be consistent typically with the diagnosis of Alzheimer's. It wouldn't prove it, but it'd be consistent with it. Okay, so what about the primary outcome? What was the correlation between change in cognition and change in CSF biomarkers? As we were discussing before after Professor Miles' study, there's often these questions about p-values and what do intermediate p-values mean, especially if they're 0.08. You sort of wonder, well, is it a type 2 error? Were we underpowered? And we were nervous going in that we might have something like that because we had 100 so patients. Fortunately, the results were unequivocal. There was absolutely no correlation. If anything, the p-value is almost 1. It's the clearest negative result I've ever had personally. Entirely wrong hypothesis, but a nice clear answer that we were completely wrong. And the nice thing about science is, as opposed to anywhere else in life where it's sort of bad to be wrong, it's okay to be totally wrong in science if you're clearly wrong. And and we asked the same question for phospho-tau, and again, the same pattern. I should just orient you to the slides in case it's not clear. So the x-axis is the 6-week change in p-tau. So a positive number means your p-tau increased in your CSF. A negative x-axis value means your p-tau decreased over that period. And the same thing for the y-axis for cognition. So a positive score means you did better on the cognitive tests after surgery as compared to before. A negative score means you did a lot worse or did somewhat worse. And again, there's no correlation at all. The p-value, again, is nowhere near significant. So that's a clear answer, but somewhat disappointing, perhaps. But we thought, well, what about those patients who did have significant changes, though, in these CSF biomarkers? What about them, and what does that mean for their brain, even if we don't see it in terms of cognitive test result difference? And so here, this is part of a collaboration with my close friend and colleague, Jeff Browndyke, who's helped us use fMRI technology to look almost like a window into the brain to see what's going on within different regions of the brain in a way that we otherwise can't see. So I'll just review in case anybody's not familiar with fMRI. So although those of us who do neuroanesthesia should be familiar with this, the basis for fMRI is basically neurovascular coupling, which we take advantage of in the neuro-ORs as well. But whenever you have an increase in neuronal and glial activity and ATP consumption via this neurovascular coupling, that induces an increase in blood flow to that region of the brain to bring oxygenated blood and more glucose to that region of the brain. At the same time, that not only displaces deoxyhemoglobin, but that neuronal activity gets integrated into larger ensembles of neurons, and that integration into larger ensembles of neurons then produces the sensory, motor, and cognitive processes that give us our conscious experience as well as our unconscious experience. The displacement of deoxyhemoglobin at the same time by oxygenated hemoglobin changes the MR signal, and we can pick that up on a timescale of seconds in the fMRI scanner. And so our goal here was to look for brain regions whose activity change from baseline to 6 weeks after surgery correlated with the tau change from preoperatively to 24 hours afterwards. And when we did that regression analysis, what we found is a very small region of the brain that showed a statistically significant correlation here in the right supramarginal gyrus. Initially, we were a little bit unsure about that because those who read about Alzheimer's disease are probably most likely to think of it as a disease that first affects the temporal lobes and the hippocampi bilaterally. But it turns out the supramarginal gyrus is actually an important part of Alzheimer's disease and how amyloid pathology spreads across the brain as well. That's the region we found there in the supramarginal gyrus. This is a paper from Annie Racine and colleagues at the Wisconsin Alzheimer's Disease Research Center, where they looked at amyloid PET scans. So these are PET scans that measure how much amyloid binding there is in the brain. And they regressed those images and the PET density for amyloid by the CSF tau to A beta ratio. And what they came up with in this heat map is, again, an area in the supramarginal gyrus, suggesting that tau pathology may help drive the spread of amyloid pathology throughout the brain out of the temporal lobe here and into more frontal brain regions in that area of the brain. So it's interesting to us that we found the same region, or one of the same regions that they found in that study, and does kind of raise this question of, is there something more significant in a small focal region of the brain that's going on that anesthesia and surgery, where they're accelerating Alzheimer's pathology? So now I'll shift into the last part of the talk very briefly and just talk about preventing neurocognitive disorders. And I'm going to talk about the Cota trial that was done several years ago and published in the Journal of Neurosurgical Anesthesiology, which, at least in my personal opinion, is one of the most fascinating studies that's been published in the last probably 10 years in our field, even though it hasn't gotten as much press as some of the higher profile publications. What the investigators did is they randomized almost 1,000 patients to either BIS-guided or non-BIS-guided anesthesia. And here's what they found when they did that. The mean BIS score in this trial was significantly higher in the patients who were having BIS-guided anesthesia than those in whom there was routine care in which the BIS monitor was placed, but it was covered up, so the anesthesiologist couldn't actually see the data from the monitor. So in other words, if you can see the data and you're told titrate to 45 to 60, that already changes what values you get than if you didn't do that. If you look at the end-tidal MAC fraction, significantly different, 0.9 of a MAC in the patients who got routine care, 0.57, about a third of a MAC less in the BIS group. The interesting and fascinating part to me is when you look at delirium and POCD rates, they're significantly lower, about 30 to 40% lower for both delirium and POCD in the patients who had BIS-guided anesthesia. Now, some people think this is a study of a monitor, but I would argue that it's really not, because I think everybody knows, or would at least grant me, simply on logical grounds, that just putting a monitor on somebody's forehead if you don't use it is unlikely to make them smarter after surgery, right? It's like a PA, and the proof of that is if it would make people smarter, I would wear one on my forehead all the time. It just doesn't seem to work. None of us do that. But the important point here is that the patients who had the monitor got a different anesthetic. It's like the debate over PA catheters. It's not whether you put in the catheter, it's how you use the data to adjust care. And so what this really says to me is if you use a third less of a MAC of gas, that translates to a 30 to 40% decrease in delirium and POCD, which is a somewhat profound thought, especially since, at least when I was a resident, like a registrar, I believe here, I was taught that once the end-tidal anesthetic is gone, it's completely gone, and its effect on the brain is completely gone. And this suggests that's not quite true. It's still having effects 3 months later on POCD. So I'll just briefly then conclude with a couple slides about a retrospective study we've been doing recently. So if it matters so much how much gas you use on patients, how much are we actually using on our patients at Duke? And are we actually decreasing it by age in accord with the known age-dependent decline in MAC of 6% per decade? So Katie Nee was a FAIR-funded medical student who worked with me several years ago on this project, and here's what we found. We looked at a large group of over 5,000 cases from Duke, and what you can see is that the observed decline in end-tidal MAC fraction is less than what it should be based on age. The dotted line is what it should be. We're decreasing by about 3% per decade, not 6%. If you do age-adjusted MAC fraction, that means we're actually giving a higher dose to our older patients. This is age-adjusted MAC fraction here, showing that it increases with age. And then you might ask yourself, well, okay, fine, but that means the BIS should be lower in older patients, right, because we're giving them more gas. And that's what we had hypothesized. But again, the nice thing about science is it's okay to be wrong. The BIS numbers actually go up with age, not down, even though we're using more gas, which is a paradoxical finding. Interestingly enough, it's a finding that Emery Brown and colleagues had predicted based on theoretical grounds about how they think the BIS algorithm works. So this results in this paradox of age, that even though the gas fraction goes up with age, the BIS numbers keep going up too, meaning that it's probably confusing to try to titrate to the BIS in older patients. So I'll just briefly close with some practical recommendations. This is from the Peri-op Neurotoxicity Working Group. A couple years ago, we had a meeting and have had a long set of discussions by email and finally submitted a paper which has been reviewed now and it will be resubmitting in a few weeks to ANA. Sorry, not the other journal that was mentioned before. One of the journals that's been overtaken by anesthesia. And here's what we came up with as a group, and I'll just review the conclusions, that everybody over 65 ought to be informed about the risks of postoperative cognitive dysfunction and delirium, including confusion, inattention, memory problems afterwards. We also thought that baseline cognition ought to be objectively evaluated beforehand, especially in older folks and in patients with pre-existing cognitive impairment. You know, it's a real irony of our field that the one organ that we anesthetize, the target organ of most of our anesthetic drugs, is the brain. Yet we don't routinely monitor the brain during anesthesia, nor do we evaluate its function before anesthesia. It's a real irony. And we think, at least in these at-risk patients, we should be evaluating the brain beforehand. Finally, we think that anesthesiologists should monitor the actual age-adjusted MAC fraction, optimize cerebral perfusion, and look at the EEG in some fashion. We didn't come to any consensus agreement on how we should look at the EEG, whether we should use the BIS, the SEDline, a raw EEG monitor. But nonetheless, I think there's enough research out there now to suggest that EEG-guided anesthetic care not only is reasonable on logical grounds, but actually improves outcomes. And finally, we need more studies to look at how to assess short and long-term cognitive function in our patients after hospital discharge in clinical practice outside of a research setting, how we should manage these patients, and what we should really tell patients about their prognosis afterwards from these. So with that, I'd like to thank a lot of people who helped do all this work. All those lumbar punctures didn't get done just by me. It took a large team. I'd like to thank Joseph Matthew, my chair and mentor, who's helped push this work forward for many years, and Mark Newman, just above him, whose work I talked about, Jeff Browndyke, who I mentioned, who did the fMRI analysis, and finally a large group of my fellow anesthesiologists who helped do all these LPs for this study and another ongoing study. And so I'll just thank our funding sources, some of our other collaborators, and my family as well. Thanks very much.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.